use non-invasive ventilations. Others maybe after discontinuations of mechanical ventilations, community acquired pneumonia and COPD, asthma, immunocompromised state. As this type of ventilation does not cause ventilator associated pneumonia, post-operative respiratory distress, in case of do not intubate status, in case of neuromuscular respiratory failure, like decompensated obstructive sleep apnea, cystic fibrosis, etc. Now coming to the applications of non-invasive ventilation, several considerations can enhance the likelihood of successful non-invasive ventilation. In addition of these factors, the experience and expertise of frontline healthcare providers like house staff, DNBs and nursing staff are utmost important, and these cannot be underestimated. The locations for application of non-invasive ventilation. It can be applied anywhere, like in ICU, in emergency department or in ward. For those patients, or those serious patients who may need endotracheal intubation, patient should be kept in ICU cell. There are different patient interfaces for non-invasive ventilation. The simplest term, non-invasive ventilation, differs from invasive ventilation by the interface between the patients and the ventilator. In case of invasive ventilations, we use endotracheal tube or tracheostomy tube. And in case of non-invasive ventilation, we use mask. There are several types of interfaces, but most commonly used are orofacial masks. Advantages are best suited for less cooperative patients, better in patients with a higher severity of illness, better for patients with mouth breathing or pursed lip breathing, better in edentulous patients, generally more effective ventilation. Disadvantages are patient feel much more claustrophobic in it. It hinders speaking and coughing during ventilation, and there is a chance of aspiration with emesis. Now coming to the nasal mask, its advantages are best suited for more cooperative patients. So better in patients with a lower severity of illness who are not mouth breathing. Patient may not feel that much of claustrophobia in it. It allows speaking, drinking, coughing, and it aids in the secretion clearance. There is less chance of aspiration and generally better tolerance. The disadvantages are it is more leaks possible, that is while the patient is mouth breathing, and effectiveness limited in patients with nasal deformity and blocked nasal passage. When patient comes with COPD, he may also have some infection of the upper airway, nose is blocked. In that condition, there are several other types of interfaces like full face mask, helmet mask, etc. And this proper fittings of this interface, another key component to successful non-invasive ventilation. The mask interface may be held in place without strap applied at first by the patient himself or therapist to familiarize the patient with mask and the ventilator. This increases compliance level. Typically, the smallest mask providing a proper fit is the most effective one. Straps hold the mask in place, but care should be given to minimize the excess pressure that may cause soreness at the face and nose, but it should be applied with that amount of force. There should not be much more of the leakage. Even the ventilators, non-invasive ventilations can be applied through ICU ventilators. Now most of the modern ICU ventilators also come with the mode of non-invasive ventilation, or with the ventilation only made for non-invasive ventilation. In case of ICU ventilators, these are little complex But we can control many more things precisely with this ventilator. Like we can control the oxygen, fraction of oxygen level, we can check the tidal volume, but the problem is that these ICU ventilators are very much leak sensitive. If there is leakage, it won't work. Non-invasive ventilations on the other hand are very simple to use. They are not that much of leak sensitive, but we can't control that precisely with this type of ventilator. In the mode of ventilations, usually non-invasive ventilations are two types. One is bilevel positive airway pressure or BiPAP. It has two components. One is inspiratory positive airway pressure or IPAP, and other is expiratory positive pressure or EPAP. The difference between IPAP and EPAP reflects the amount of pressure support ventilation provided to the patient, and this determines the tidal volume of the patient. This difference. Other type is continuous positive airway pressure or CPAP. Here, both inspiratory and expiratory part, similar pressure is applied. That is why it is called continuous positive airway pressure. It is useful in congestive heart failure and in obstructive sleep apnea patients. The patient suffers from obstructive sleep disorder. They usually sleep with this ventilator with using usually a nasal type of interface, nasal mask. Initial ventilator setting and adjustment should be like this. Our primary goal is adequate ventilation, correction of respiratory failure, and adequate patient tolerance and comfort. To achieve this endpoint, we should try to reach an adequate tidal volume, that is 7 ml per kg. We reduce respiratory rate to less than 25 breaths per minute. Oxygen is adjusted to achieve adequate oxygenation, that is around SpO to 90%. We do serial ABG measurements, monitor the response, and further readjust the mode and pressures. We start with IPAP 10 cm of H2O and EPAP 5 cm of H2O. Pressure less than 8 cm of IPAP and 4 cm of EPAP usually not adequate. Initial adjustment to achieve tidal volume is 5 to 7 ml per kg. Subsequent adjustment based on ABG values. We usually increase IPAP by 2 cm of water if there is persistent of hypercapnia. With increasing IPAP, the tidal volume will increase and it subsequently increase the minute volume. So there is a chance of washing away the carbon dioxide from the blood. If there is a persistent hypoxemia, we usually try to increase IPAP and EPAP both by 2 cm of water. With increasing of the EPAP, this will act like increasing of positive expiratory pressure, and it will help with oxygenation of the blood. The maximum IPAP is limited to 20 to 25 cm of water to avoid gastric distensions, and it also improves patient's comfort. Maximum EPAP is limited to 10 to 15 cm of water. The fractionated inspiratory oxygen, we may start with 1.0, that is 100%, and adjust to lowest level with an acceptable pulse oximetry value. In case of COPD patient, it is around 90%, not more than that. And we can back up the respiratory rate 12 to 16 breaths per minute. It is not available in non-invasive ventilation, only ventilators. Now coming to the predictors of non-invasive ventilation. The predictors of success. This is the response after 2 hours of trial. If we get the following response, we may say that there is a chance of successful use of non-invasive ventilation. The patient may get better with non-invasive ventilation only. That is a decrease of PaCO2 greater than 8 mm of mercury after 2 hours of non-invasive ventilation. improvement in pH, that is greater than 0.06, and corrections of respiratory acidosis. Now coming to the predictors of failure. Before start of non-invasive ventilation, very severe disease like acidosis, pH less than 7.25, hypercapnia more than 80 and pH less than 7.25, Apache 2 score higher than 20. Also the level of consciousness, neurological score more than 4, then stuporous or arousal only after vigorous stimulation, encephalopathy score more than 3, major confusion, daytime somnolence or agitation, Glasgow Coma Scale less than 8, or failure of improvement with 12 to 24 hours of non-invasive ventilation. So when we should go from non-invasive ventilation to invasive ventilation? That means our incubation guidelines. No consensus has been reached yet, but there are many criteria. Like major criteria, if a patient fulfills any one of the following, we may go for invasive ventilation. That is respiratory arrest, heart rate less than 50 per minute with loss of alertness, hemodynamic instability with systolic blood pressure less than 70, pH less than 7.2, pH 7.20 to 7.25 in 2 occasions, 1 hour apart, or hypercapnic coma, GCS less than 8, and TSCO2 more than 60 millimeter. And there are also some minor criteria. Patient should fulfill at least 2 of the following. The respiratory rate greater than 35 breaths per minute or less than 6 breaths per minute. PaO2 less than 45 millimeter of mercury. Tidal volume less than 5 millimeter per kg. Blood pressure changes with systolic less than 90 millimeter of mercury. Oxygen desaturation to less than 90% despite adequate supplemental of oxygen. Hypercapnia, PaCO2 more than 10 millimeter increase, or acidosis, pH decline more than 0.08 from baseline, and abdominal paroxysmal respiration. So coming to the non-invasive ventilation in COPD, patients with exacerbations of COPD and hypercapnic respiratory distress or respiratory failure most likely to be successfully treated with non-invasive ventilation. Exacerbation increase respiratory load through increasing hyperinflation, decreased diaphragmatic excursions and strains, increased intrinsic PEEP. In case of COPD patients, patient cannot exhale properly. So there is a air trapping inside the lung, and this air increases the positive pressure inside the lung. This is called the auto PEEP or the intrinsic PEEP. Ineffective or inadequate tidal volume generation, change in the respiratory pattern, and increase in respiratory frequency. Due to hypercapnia, patient respiratory rate increases, but with the increase in the respiratory rate, the expiration time decreases. So it also hampers CO2 washout. Non-invasive ventilation effectively unloads the respiratory muscles. It increases tidal volume, decreases the respiratory rate, and decreases diaphragmatic work of breathing, which translates into an improvement in oxygenation, a reduction in hypercapnia, and an improvement in dyspnea. A protocol in short for application of non-invasive ventilation in this type of patient. Patient interface, usually use oronasal mask. Mode of ventilation is BiPAP here. First we explain the therapy and its benefit to the patient in detail, including the possibility of intubation. Start with a very low setting, that is IPAP 6 to 8 cm of H2 and EFAP is 2 to 4 cm of H2. The difference between IPAP and EPAP should be at least 4 cm of water at all times. Otherwise, patient won't get the adequate tidal volume. We start with oxygen at 2 liters per minute. We hold the mask with hand first over the face and do not fix it. We increase the EPAP by 1 to 2 centimeter increment until the patient's effort able to trigger the ventilator. If the patient's inspiratory effort does not initiate the ventilator, that means it can't trigger the ventilator, it indicates that patient has not generated enough respiratory effort to counter his auto-PEEP. This time we increase EPAP further until this happens. It means that until the patient can initiate his or her breath, can trigger the ventilator. Most patients require EPAP of about 4 to 6 centimeter of H2. We leave the EPAP at this level. Now we start increasing the IPAP in increment of 1 to 2 centimeter up to a maximum pressure in which the patient can tolerate without discomfort and with no major leak. If inspiratory time can be adjusted, it is kept around 1 second. Now we secure the interface with head straps, increase the oxygen to bring SpO2 around 90%. Setting may be different in wakefulness and in sleep, and readjust them accordingly. COPD is the most suitable condition for non-invasive ventilations. In different meta-analysis, it shows non-invasive ventilation decreased the intubation rate by 28%, decreased hospital mortality rate by 10%, absolute reduction in length of stay by almost 4.5 days. The benefit more pronounced in severe COPD exacerbation, that is to the patient in whom presented with initial pH less than 7.30. It decreases the intubation rate by 34% in this type of patient. There is mortality reductions by 12% and absolute reductions in the length of stay by 5.59 days. The hypercapnic respiratory acidosis may define the best responders, that is the patients with pH around 7.20 to 7.30. The lowest thresholds of effectiveness is unknown, but there is also case report about success has been achieved with pH as low as 7.10. Now coming to non-invasive ventilation in cardiogenic pulmonary edema. Non-invasive ventilation in cardiogenic pulmonary edema, it is another condition in which we can effectively use non-invasive ventilation. Usually there is a respiratory failure is also associated with CHF, congestive heart failure. It's related to pulmonary vascular congestion with interstitial edema and also with alveolar edema. This leads initially to hypoxemic respiratory failure, which further deteriorates to hypercapnic respiratory failure. Here the positive pressure ventilation is beneficial because it recruits alveoli, more alveolus become functional, it increases the functional residual capacity, it decreases the work of breathing because here the lung compliance decreases, improve ventilation perfusion relationship and eventually correct the hypoxemia and hypercapnia. In patients with volume overload, positive intrathoracic pressure also decreases the preload and left ventricular afterload. But here the mode of ventilation is not BiPAP, here the mode of ventilation is CPAP. That is the continuous positive airway pressure. There are some studies in which it has been shown that in this type of patients, if we apply BiPAP ventilation, there may be a chance of more myocardial infarction. With CPAP ventilation in this sort of patient, there is reductions in intubation almost about 60% and decrease in mortality rate about 37%. Now coming to non-invasive ventilation in weaning strategy. That is, non-invasive ventilation also can be used after extubation. This non-invasive ventilation is effective as a bridge support after early extubation. To the patient who are difficult to wean, difficult to extubate, we can extubate them faster with the use of non-invasive ventilation. So it's an adjunct to winning strategy. Patients with underlying COPD are most likely to benefit from non-invasive ventilations after early extubation. It reduces the ventilator-associated pneumonia rate by almost 71%, and the durations of endotracheal intubation is reduced by 7.8 days. So we can say that non-invasive ventilation is simple. There is no need of any special skill like endotracheal intubation or tracheostomy. No intimidating looking ventilator with many switches and many parameters to follow. This is very simple to use, but yet it is very safe. The complications